Okay, so right away, I mean, it is, of course, the femoral nerve is coming from the lumbar plexus. It's a little bit of a lost art nowadays, so it's a very, very big nerve coming from L2, L4. You've got a lot of motor branches and also the complete sensory medial aspect of the leg, except the small part where you see the obturator is innervating as well. So if you look at where exactly you will have to put this femoral nerve, you got a very nice picture there, and what is the main indications for that? I would say it still is for knee surgery, for hip fractures, anterior hip surgery, quadriceps repair, you name it. We still do it a lot in limb amputations as well, combined with sciatics, and putting in catheters there, because we started a project for lessening postoperative chronic pain on limb amputation with very good effects, putting in femoral catheter and sciatic catheter together with multimodal analgesia and having very good effects on that. So, like I said, it is a little bit of a lost art, especially with the arrival of the fascia iliaca block and the adductor canal block, but it still has its indications, to be honest. So, there are some clinical difficulties. I usually hear people say, well, it's the most easy block there is. There's not a lot of anatomical landmarks. There's just the femoral artery, the femoral vein, you've got the nerve there, the fascia iliaca, and the iliopsoas muscle, and that's about it. And they say, really, it's an easy block. But to be honest, I see a lot of people struggle with femoral nerve block. Even my good residents, they're not doing it as much as they used to. And there are some technical problems there. And I see a lot of people struggle, and they can see their nerve up front, but when they perform the block, it's like very difficult sometimes. And I mean, the first difficulty is that it's a very flat nerve. Although it's big, like I demonstrated in my first slide, it is unbelievably flat. I mean, it's just sandwiched between that iliopsoas muscle and the fascia iliaca, and it's like very long, but it's not big and round like you would expect, and that's the main problem you already see. And it's sometimes very difficult. And there's also a part which makes the difficulty is that the anatomy is not always really known. I mean, there are some textbooks who still say, well, it's the triangle next to the femoral artery, which actually is not okay. I mean, I put in this nice slide from a block we performed, and you can see the triangle next to the artery there is exactly not a location where the femoral nerve is. And that's another problem. People don't know their anatomy. And also people tend to scan too low. I mean, even if it's a big nerve, it immediately branches into all these several parts. And if you scan too low where the bifurcation is already, you will see only small little fragments. You really have to go high up to have a good view. And there are sometimes you can have some anatomical differences as well. Arteria circumflex can run through the nerve or run in between, and that can prove also difficult. And what I usually see is that when they start doing that block, they're not in the wrong position. They can see it a little bit, but then they really start at the wrong entrance point, and then they struggle finding their needle and end up much lower or higher where they want to be. So the clinical pearls is that you really need tilting, and you almost need for every technique tilting, but especially here in the femoral nerve, it's really, really important. And I've added the anatomy is like it should be. The femoral nerve is under the fascia iliaca block, like you see in the drawing next to it. And I added some of the wrong images you can find on the internet, and there you have it. They're just showing the femoral nerve like that, while I've just demonstrated it's completely underneath that fascia iliaca and not the portion where they show next to the triangle. So people don't visualize as well. And what's really important as well is that sometimes you have to do some belly lifting. Remember, if there's an indication, it's going to be for knee surgery or hips. They're usually a little bit fatter patients. If you see my model, it's always much easier. But in a real patient, usually femoral nerve block, you'll have to lift that abdomen a little bit. So be careful for that, and use a long needle. That's another problem which I see, is that they're not coming from lateral enough, and it's a long, like I said, remember, it's a long nerve, and it's very flat, and sometimes the exact border is not completely visualized, and if you come too close to the probe, you're much likelier to go into the nerve and have an intraneural injection. So come from the side, use a long needle, and that's very, very important. And I usually come really from the side, so I know that I'm in that exact angle. So this is for my presentation. I'm going to show the model now.
Great, thank you, Steve. When we listen correctly to what Steve has said, there are two extremely important points, I believe. It is the circumflex artery. The circumflex artery is coming from the femoral artery and is lying, going externally to the joint, and is lying on the top, on the roof of the fascia iliaca. So once you have correctly visualize this artery, you perfectly know that the femoral nerve is just below this one. The second point, important, and it will show it to you immediately, is to go at the level of the bifurcation, or just above the bifurcation of the two femoral arteries. Now we are going to listen to Steve on the other side. Great.
Okay.
And he has a very nice nerve there.
Again, on models like these, it's much easier, of course. But here you have a very nice vision. You can see the femoral nerve there, which is compressed when you press hard. I've got the femoral artery there. If I go a little bit down, you can see the bifurcation, but I won't. I'll be staying high up. Like this, you would be tempted to say, well, it's that whitish triangle, but look what happens when I tilt, and then you can see the nerve here, and it's really nice. And you can see it actually under that fascia iliaca. You can sometimes see the nerve moving a little bit with the muscle, completely separate from the triangle, which isn't that moving that much. And you can actually really see, if you tilt a little bit, the black spots, the honeycomb structure which is in there. And sometimes it can differ also, that it could be a little bit more laterally, it could be more medially as well. So you see it tends to run underneath the artery here, so it's much longer than you would expect here. So it's a very, very good overview of what you would expect in a patient. It's a very nice view. Look at the tilting, which changes completely everything. If you look like that, you won't be seeing anything. And I would be coming from really lateral here. And you can see my fingertip coming here, coming there, just going underneath that fascia iliaca. And you can choose to go underneath the nerve. You could choose to go on top of the nerve. I mean, if you go underneath and you inject local anesthetic underneath the nerve, you will have 50% of the nerve surrounded underneath, and you will have a good block. Usually when I tend to put in a catheter, I tend to try to go above the nerve, because the catheter is more lodged in between the fascia iliaca and the nerve. But still, you don't have to do that. It's just an option. I usually do that. Okay?
So great. The first questions will be devoted to you, because you an expert in the canal adductor block, and my question is the following. Do you still use femoral nerve block?
Yes, Philip, we use the femoral nerve blocks sometimes for hip procedures, but sometimes we prefer a fascia iliaca compartment block. But it depends on the patient, the indication, and what is possible. We use it sometimes as an alternative to fascia iliaca compartment block. We also often use it for femur procedures. It could be osteosynthesis of femur fractures. Then we also use femoral nerve blocks.
Yeah, exactly. I mean, it depends on the patient and the procedure. If you have a lateral approach on hip procedure, I would go for fascia iliaca block because you have your cutaneous femoral nerve. But if you know it's an anterior, you would go for a femoral, to be honest. And we still use it as well for total knee repair, because in our hospital we don't tend to let the patient go that early like in some hospitals, and it's still a very good approach as well. I mean, adductor canal block is excellent, and I use it as well, but femoral is still a very, very good and consistent approach. And I usually tend to discuss with surgeon if he really wants an adductor canal block, then I say that's okay, but don't use a tourniquet, because tourniquet already means 20 to 30% less quadriceps function afterwards. So I tend to say I'll put in a adductor canal block if you leave the tourniquet behind, and especially if you have a revision of a total knee arthroplasty, I would go for femoral anyway. If it's a revision, you don't have to walk the next day. I would always go for a femoral with catheter, and otherwise it depends on the surgeon and what they want and on the patient.
Mm-hmm. So for major knee surgeries, a redo, you still use femoral catheters?
Absolutely. Yeah, absolutely.
And what you have said that is extremely interesting is that you said it is consistent.
Yeah, it's very
There is a very low failure rate.
It's very consistent. Yeah, absolutely.
You know exactly, you inject and you perfectly note that all your four muscles are
absolutely. And
involved.
That's the main problem with adductor canal. The literature is already so diverse, because is the mid thigh, is that subsartorial injection, or is it a real adductor canal? And if you go lower, you have maybe it's different. I mean, femoral is femoral. You know what you get. You don't expect anything else but very good pain relief. You will have quadriceps muscle weakness, but you know what to expect. You don't have any surprises.
About the muscular weakness, do you really believe it is an important problem with the femoral catheters?
That's a very good question.
It is one
well, again, I'm not sure if that's the only thing. And like I said, tourniquet is also very important. And to be honest, and that's what really lacking in a lot of studies, is that there's so many different approaches to knee surgery. I mean, look at the literature. You have a scorpioprothesis, you've got a hemiarthroplasty, you've got people who use a subfastus approach, you have people who cut the patellar ligaments. I mean, if you cut the patellar ligaments and then reinsert afterwards, you already cut the infrapatellar nerve ending from the femoral nerve, which is one of the main advantages of the adductor canal. It's the infrapatellar branch. You already cut that. So it's really depending on the surgery type. So there's so many differences there. So it's really difficult to say what's the main factor.